I invite Dr. Diana. She's a second-year resident in Universitas Indonesia, and she will present a glaucoma case with the use of multiple glaucoma drugs. So please, Dr. Diana, you can start your presentation.
Thank you, Dr. Mehta. Assalamualaikum warahmatullahi wabarakatuh. Good evening, Professor, Doctor, and all participants. My name is Diana from Kirana Cipto Mangunkusumo Hospital. In this opportunity, I will present a case presentation about multidrug treatment in glaucoma. The patient was male, 73 years old, with chief complaint blurry vision of the right eye since 1 day before admission. The patient felt blurry vision of his right eye after secondary IOL implantation. He felt discomfort on his right eye. History of redness, pain, headache were denied. No complaint from his left eye. History of cataract surgery of the right eye in 2000 and the left eye in 2001. History of vitrectomy and explantation IOL drop of the right eye in February 2016. History of secondary IOL implantation in 2017. There is no family history of glaucoma, history of hypertension since 14 years ago, and no history of diabetes, allergy, and spectacle use. From ophthalmological examination, the visual acuity of the right eye was 6/45 with IOP 40 mm of mercury. The lens was IOL. The fundus is cup-disc ratio 0.8 to 0.9 with cupping and nasalization. From the left eye, the visual acuity was 6/6 with IOP 14 mm hydrogerum. The lens was IOL and the fundus is cup-disc ratio 0.5 to 0.6, cupping and nasalization. Gonioscopy of both eyes was 4 at all quadrants. These are the OCT pupil and Humphrey of both eyes. As we can see, the OCT pupil of the right eye showing thinning at inferior, superior, and temporal part. The OCT pupil of the left eye shows thinning at inferior and the end nasal part. Humphrey field of the right eye showing generalized depression, and the Humphrey field of the left eye show defect at the superior part. We assess this patient with mixed mechanism glaucoma of the right eye, primary glaucoma of the left eye, and pseudophakic of both eyes. We plan to give acetazolamide 3 times orally, kalium aspartate 2 times orally, and timolol twice daily of the right eye. Also consideration of implant of the right eye. We follow up this patient in 2 weeks. In May 16, 2017, the IOP was 15 mm hydrogerum, so we stopped the oral acetazolamide and adding brinzolamide 3 times of the right eye. 2 weeks later, at May 30, 2017, the IOP of the right eye was 25 mm of mercury. We added latanoprost once daily to this patient. So in June 2017 till April 2018, the IOP was 9 till 14 mm of mercury with these three drugs. In August 2018 till March 2019, the IOP was 10 to 15 mm of mercury. So we tried to stop brinzolamide and give only 2 drugs, and the IOP was around 10 to 15 mm of mercury. On July 2019 till November 2020, with using 2 drugs, the IOP was around 11 to 16 mm of mercury. The visual field testing on November 2020 of the right eye cannot be read due to the high fixation loss. On August 2021 and December 2021, the IOP was 17 to 22 mm of mercury. We adding another 2 drugs, brinzolamide and brimodine tartrate, twice daily. And the Humphrey of the right eye show generalized depression, and the left eye cannot be read due to high fixation loss. In April 2022, the IOP was 9 mm hydrogerum, so we stopped 1 drugs, which is brimodine tartrate. The Humphrey test on April 2022 still same as before. On July 2022, the visual acuity decreased to 6/60 or 6 meter finger counting with IOP 21 mm of mercury with these 3 drugs. So we added brimodine tartrate twice daily in consideration for implant of the right eye. But on September 2022, the patient came again with visual acuity 6/45 with IOP 11 mm hydrogerum with these 4 drugs in the last 3 months. So these are the bar chart for IOP of the right eye since 2017 until 2022. As we can see, the IOP was fluctuate with 2 to 3 drugs. and control with 4 topical drugs. Anti-glaucoma medication. The aim of anti-glaucoma medication is to preserve visual function by lowering the IOP. Anti-glaucoma medication are divided into several classes, but based on chemical structure and pharmacological action. The first one is prostaglandin analog, adrenergic drugs, carbonic anhydrase inhibitor, oral and topical, parasympathomimetic agent or miotics agent. The fifth one is hyperosmotic agent and rhokinase inhibitor. The first one is prostaglandin analog. Prostaglandin analog are the prodrugs that penetrate the cornea and become biologically active after being hydrolyzed by corneal esterase. The mechanism of action by increasing the aqueous humor outflow via the uvascular pathway and decreasing the outflow resistance. Currently, prostaglandin analog in clinical use such as latanoprost, travoprost, bimetopros, and taflupros with dosage once daily can decrease the IOP 25 until 33%. The adverse effect of prostaglandin analog, the first one is increased iris pigmentation, which is permanent, hyperpigmentation of the periocular skin, conjunctival hyperemia due to vasodilatation, hypertrichosis, trichiasis, and dystichiasis can be reversible if the drug discontinue, and also prostaglandin-associated periorbitopathy. In patient, we can see deepening of the superior sulcus and ophthalmos due to periorbital fat atrophy. The second one is adrenergic drugs. Adrenergic drugs, the first one is beta-adrenergic antagonist or beta blocker. Beta blocker can lowering the IOP by inhibit cyclic adenosine monophosphate production in the ciliary epithelium. 5 topical beta blocker are approved for the treatment of glaucoma is betasolol, which is betasolol is the only topical beta-1 selective antagonist, but less effective than the non-selective antagonists such as casteolol, levobunolol, metipranolol, and timolol. With doses twice daily, they can decrease the IOP from 20 to 30%. The local side effects such as blurring, corneal anesthesia, and the systemic side effect such as bronchospasm, bradycardia, lower blood pressure, and CNS depression. The second one is alpha-2 adrenergic agonist. Alpha-2 adrenoceptor can be found on the ciliary epithelium, can reduce the activity of adenylyl cyclase and intracellular concentration of cyclic adenosine monophosphate, so can reducing the aqueous humor production. The example of these drugs is brimodidine tartrate and apraconidine with dosage 2 to 3 times, can decrease the IOP from 20 to 30%. The local side effect is follicular conjunctivitis and contact blepharodermatitis. The local side effect is lower with brimodidine than with apraconidine. Carbonic anhydrase inhibitor. Enzyme carbonic anhydrase is present in many tissue such as corneal endothelium, iris, and retinal pigment epithelium. Carbonic anhydrase inhibitor inhibit this enzyme and can decrease the aqueous humor production. CAI can be topical and systemic. The topical one is dorzolamide and brizolamide, and the systemic is acetazolamide and metazolamide. The local side effect such as taste disturbance, blurred vision, and burning upon instillation. The systemic side effects such as paresthesia on finger and toes, loss of energy, anorexia, weight loss, abdominal discomfort, and diarrhea. The next one is parasympathomimetic agent or miotics. Miotics agent can reduce the IOP by contraction of the longitudinal ciliary muscle that insert to the scleral spur, trabecular meshwork, and inner wall of slime canal, thereby improving the outflow facility by causing an unfolding of trabecular meshwork and widening of the slime canal. The example of this drug is pilocarpine that can decrease the IOP from 15 to 25%. The local side effects such as miotics can be cataractogenic, and the use of the miotics occasionally induce the paradoxical angle closure, and also can make epiphora due to direct lacrimal stimulation and punctal stenosis. The systemic side effects such as increased salivation, increased secretion of gastric, abdominal cramps, and bronchospasm. The next one is a hyperosmotic agent. Hyperosmotic agent increase blood osmolality, that creating an osmotic gradient between the blood and the vitreous humor that draws water from vitreous cavity to the circulation and reduce the IOP. Because the increased gradient, the higher dose that we administer and the more rapid administration, the greater IOP reduction will be. The example of these drugs is mannitol and glycerol can decrease the IOP from 15 to 25% with local side effect is rebound elevation of IOP. And the systemic side effects such as acute congestive heart failure, ketoacidosis in diabetic patient, nausea, vomiting, diarrhea, electrolyte disturbance, and hyperglycemia. The last one is rokinase inhibitor. The mechanism of action is relaxing the cytoskeleton of outflow cell in the trabecular meshwork and slime canal that increasing trabecular outflow facility. Example of these drugs is ripasudil and intarsudil with dosage once daily. This drug can decrease the IOP 20% with local side effects such as conjunctival hyperemia, which occur more than 50% of patients due to the conjunctival vascular smooth muscle relaxation. In conclusion, mechanism of action anti-glaucoma medication is to increase aqueous outflow, such as prostaglandin analog, alpha-2 adrenergic agonist, cholinergic, and rokinase inhibitor, and also decrease in aqueous inflow, such as alpha-2 adrenergic agonist, beta blocker, and carbonic anhydrase inhibitor. Thank you for your attention. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Dr. Diana, for the case presentation. And thank you for including the overview about the current glaucoma medication and how they work before we hear the lecture regarding the novel glaucoma meds. So now we should proceed to the lecture first from Dr. Rhuju Mehta. She is an ophthalmology consultant at the Lions Eye Institute in Royal Perth, Australia, specializes in glaucoma. Besides being clinicians, she's also actively involved in training of ophthalmology registrar and medical students in Western Australia. So please, Dr. Rhuju, you may start your lecture.
Thank you, Archie, and thank you, Diana, for that summary. Great. Okay, you can see my slides there?
Yes, clearly.
Excellent. Okay, good. All right. Okay. I'll be talking about the novel glaucoma medications. When we think of these novel agents, we can divide them into two categories, the IOP lowering agents or the neuroprotective agents. It's quite a big topic to cover with a lot of agents to talk about, but I'll try and just give you a general overview of what's available and what's in the pipeline at the moment. As Dr. Diana spoke about, there are issues with current glaucoma medications, and the types of medications we have at the moment are all IOP lowering agents, and they come with local and systemic side effects. And we also know that some patients fail to respond to medications altogether, and some lose response over time and develop tachyphylaxis. So there's really an unmet need for medical management options that don't have these side effects and also work well in all patients. And that's the holy grail of IOP lowering agents. In terms of what is currently available, there are three agents. One is omidinipeg, the second is rho kinase inhibitors, which Diana spoke about earlier, and the third is latanoprostene bunod. Now, we'll start by looking at omidinipeg. It's an agent that is approved for use in some countries, not yet available in Australia, and I don't think it's available in Indonesia either. It's a EP2 receptor agonist, so prostaglandin 2 receptor agonist, and once a day dosing. It's similar to other prostaglandin analogs like latanoprost, but it doesn't bind to the same receptor. So it binds to the, those agents bind to the prostaglandin F receptor and thus increase intracellular calcium. So this agent doesn't do that. So it doesn't lead to the same prostaglandin-associated side effects of periorbital fat pad atrophy and lash hypertrophy. It works by increasing both uveoscleral as well as trabecular meshwork outflow through changes in ciliary muscle contractility and dilation of the Schlemm's canal. So this is a image of the outflow facility studies on this drug. And you can see that both trabecular outflow facility as well as uveoscleral outflow has been increased with this agent. Most of the data for this drug comes from clinical trials conducted in Japan. In terms of IOP lowering, a phase 3 trial of 250 patients showed that it was non-inferior to latanoprost, with an IOP reduction of about 25%, whereas in the same study, the IOP reduction for latanoprost was 28%. So quite good IOP reduction. It seems to be effective in lowering pressure in patients that are non-responders to latanoprost. So a smaller trial of 24 patients that didn't respond to latanoprost and were switched to almadenapeg showed that they did respond to this agent. Thirdly, and interestingly, there's no additional IOP lowering when it's used with a traditional prostaglandin analog. So even though it acts on a different prostaglandin receptor, its role is probably just limited to those that can't tolerate traditional prostaglandin analogs due to the side effects or show a lack of efficacy. In terms of the side effect profile, it causes conjunctival hyperemia at fairly decent rates of 20 to 30%. Interestingly, the incidence of cystoid macular edema with this agent is higher than with latanoprost. And in the studies, it occurred exclusively in pseudophakic and aphakic patients. So phakic patients did not develop CMO. The risk of anterior uveitis and also increased corneal thickness, of which the mechanism is unknown. In terms of benefits over traditional prostaglandin analogs, as we said, there's a lack of prostaglandin associated side effects because it doesn't bind to the FP receptor. It appears to be well tolerated and effective in patients who don't respond to traditional prostaglandin analogs. It should be avoided in patients with a history of aphakia, pseudophakia, CMO, and uveitis. This is as per the drug company's recommendations because of those higher risks of cystoid macular edema. In terms of use with other agents, it's been looked at in conjunction with timolol, but in conjunction with other glaucoma agents, its safety is not yet confirmed. So it's still undergoing further studies on that front. Moving on to Rho kinase inhibitors, the commercially available agents are Rapazidil and Natazidil. Rapazidil is available in Australia via the Special Access Scheme for refractory glaucoma, but it's quite expensive. It's about $90 a bottle. There's a newer agent called Fazidil, which is undergoing clinical trials, but not yet available. In terms of the mechanism of action, it increases trabecular meshwork outflow by loosening the endothelial adhesions in the Schlemm's canal and increasing the permeability of the canal, and also reduces extracellular matrix production in the Schlemm's canal and widens gaps, the cell gap in the trabecular meshwork, so increases permeability. So that's one mechanism. The second thing it does is quite interesting. It reduces the episcleral venous pressure, so it expands the episcleral venous plexus and reduces the downstream pressure. So this image basically shows how Rho kinase inhibitors effectively remodel the trabecular meshwork outflow pathway. And if we look at their dosing, it's a once-a-day dose. The side effects are conjunctival hyperemia, presumably because of that relaxation of smooth muscle in the vessel wall, which tends to be the thing that gives you the conjunctival hyperemia. blepharitis, eye pain. Nitazoxanide can also cause corneal verticillata. In terms of efficacy, the IOP lowering appears to be non-inferior to timolol, with a 20 to 25% IOP lowering effect. And interestingly, the efficacy increases as you use this agent more, and that's probably because of the trabecular meshwork remodeling action. So the efficacy has been shown to increase from month 1 to month 6 of use. It appears the IOP lowering effect appears to be independent of the starting pressure. So probably an effective agent in normal tension glaucoma because you can modulate the episcleral venous pressure. It's effective in the open angle glaucoma subtypes and in all patterns of treatment initiation. So mono versus combination therapy, which I'll talk about in a minute. But obviously the status of the trabecular meshwork will affect how effective this agent is. So if you've got a closed angle with no trabecular meshwork accessible, then Rho kinase inhibitors will have little effect. In terms of combination agents, there is this agent rocklatan, which is available in the US, which was recently FDA approved, which is a combination of nitazoxanide and latanoprost. And there have also been studies that have been shown that it's safe and efficacious for use with beta blockers. In terms of use in patients on multiple glaucoma medications, so this was the only paper that I could find that looked at the use of rapazidil in patients on maximal medical therapy and uncontrolled IOP. And this was just published in June this year. It's a small study. There was 27 patients in this study, so 46 eyes, and they were on maximal tolerated medical therapy. And this meant different things, but I'll go through that in a minute. But they were treated with rapazidil and monitored over 3 months. And if we look at the number of medications that these patients were on, most of them were on 3 or more medications. So this is what the definition of maximal medical therapy was in this study. In this study, 22 of the 27 patients developed mild and transient conjunctival hyperemia, but none of them had to cease treatment due to the adverse effects. The mean starting pressures were 16 and 18, and mean cup disc ratios were 0.8 and 0.7 in the right and left eyes. The study found that all patients had an IOP reduction, and this was the maximum IOP reduction was achieved at 3 months. So the mean IOP at 3 months in these patients in the right eye came down to 11.3 and left eye came down to 12.2. So it's quite an interesting little study because if we're looking at patients that are already on maximal medical therapy that we're now considering surgery, and it may be one to consider, but obviously this is quite a small study. Latanoprostene bunod is a drug that is a nitric oxide donating PGF2 alpha analog. So what this means is that the drug itself metabolizes into 2 agents. So one is latanoprost, and the other one is butanediol, which sorry, let me just bring a laser pointer up. The other is this agent butanediol. So this butanediol metabolizes further to release nitric oxide. So the 2 active metabolites that are the result of this drug are latanoprost and nitric oxide. So it can sort of be thought of as latanoprost with a bit extra. Latanoprost, as we know, increases uveioscleral outflow, but the nitric oxide dilates and relaxes smooth muscles in the Schlemm's canal and trabecular meshwork cells. So it's thought to help increase trabecular outflow as well. So in terms of the efficacy of this agent, a study in 2015 of 418 patients found that the mean IOP reduction with this latanoprostene bunod was greater than with latanoprost alone, with similar local side effects. Once again, the dosing is just once a day, and the side effects are similar to the traditional prostaglandin analogs. If we go on to look at cannabinoids, I'll talk about this briefly, but basically cannabinoid receptors are found all throughout the eye, and the oral, inhalational, as well as topical routes have been investigated. The topical route is a little bit problematic because the cannabinoid is lipophilic in nature, so it's hard to find a vehicle that is able to deliver the drug to the eye and is also well tolerated by the ocular surface. The studies on the oral and inhalational routes have shown modest IOP reductions, which have an onset within 30 minutes. However, they have a very short duration of action. So this means multiple doses are required throughout the day to lower the pressure in a meaningful way. Also, there is a finding of tachyphylaxis, so patients have to have higher doses over time. And obviously there are side effects with cannabinoids, including postural hypotension and mood disturbances and impaired cognition. It's also thought to have a neuroprotective effect by the inhibition of glutamate release. However, their role in glaucoma management at the moment is equivocal because of all these issues. We'll move on now to talk about the neuroprotective agents. So, as we know, glaucoma is a progressive optic neuropathy in which intraocular pressure plays a role, and this is what we are focused on modulating at the moment. However, as we know, patients can and do progress despite low pressures, and there is more contributing to the neurological injury in glaucoma than intraocular pressure alone. Sometimes these non-IOP related factors, such as defective vascular autoregulation or systemic hypotension, are identifiable and treatable. Sometimes they're not. And a neuroprotective agent would be an agent that protects these neurons from injury regardless of the underlying cause of glaucoma, which would obviously be a useful addition to our glaucoma treatment armamentarium. Retinal ganglion cells and their axons degenerate in glaucoma, and there's a window of opportunity between the injury, which is the raised pressure, or there's a window of time that passes between the raised intraocular pressure insult and the death of retinal ganglion cells. And if we can intervene and mitigate some of this retinal ganglion cell damage by using neuroprotective agents, that may be able to minimize the retinal ganglion cell death. You can see here the initial IOP causes changes in the metabolic pathway, which causes damage of axons, and the actual retinal ganglion cells dilate. And this can even be up to 18 to 24 months after the initial insult occurs. There are barriers to conducting trials of neuroprotective agents. Firstly, because glaucoma is a slowly progressive disease, so it can take many years to show benefit from a neuroprotective agent in bending the curve or modulating the outcome of glaucoma. And secondly, trials tend to look at, because of this reason, trials tend to look at neuroenhancement, so recovery of sick or injured retinal ganglion cell, or have their endpoints in electrophysiology rather than visual field, which is what we're truly interested in these patients. So we'll now talk about the types of neuroprotective agents. And if we look at the propagation of cell damage or cell death, what happens is we have initially an insult to the optic nerve, such as increased IOP or ischemia, that causes a deprivation of neurotrophins and also increases the levels of glutamate, extracellular glutamate, which activates the NMDA receptor. This causes an influx of calcium into the cell, and this results in increased levels of nitric oxide and other free radicals within the cell, which damage the mitochondria and the cell structures, which cause retinal ganglion cell death. We have agents at various points where we can act to try and try and instigate some neuroprotective effect, and we'll talk about these drugs in more detail, starting with memantine. And before we talk about memantine, I'll just briefly talk about the process of glutamate excitotoxicity. So glutamate is a neurotransmitter in high concentrations in the retinal ganglion cells. It's released by the retinal ganglion cells in response to injury, and high levels of glutamate have been found in the vitreous of patients with glaucoma, and with higher concentrations found in those eyes that have worse disease. The glutamate causes overstimulation of the NMDA receptor, which causes an influx of intracellular calcium and activation of nitric oxide synthase, free radical accumulation, and mitochondrial dysfunction and cell death. Memantine is an agent which blocks the NMDA receptor and prevents this overstimulation from glutamate from taking place, and also reduces the calcium influx. It's actually available in Australia on the PBS for Alzheimer's disease and is being investigated for other neurodegenerative diseases. However, if we look at the studies in glaucoma, a few years ago, it was getting a lot of attention. However, a large phase 3 trial, which was done in 2018, involving 3,000 patients who were followed up for 4 years, found that oral memantine didn't actually show any decrease in glaucoma progression. So it appears that at this point, memantine has lost a bit of steam, as the current literature doesn't appear to show a neuroprotective effect in glaucoma. If we now move on to looking at vitamin B3, there are several lines of evidence that implicate the oxidative stress and mitochondrial dysfunction in aging, but also in retinal ganglion cell loss in glaucoma. NAD is a cofactor in ATP production in the mitochondria, and its role is in neurodegenerative diseases gaining attention. Numerous studies have shown that repletion of NAD can be beneficial in disorders like Alzheimer's disease and peripheral neuropathies, and those studies are underway. In terms of glaucoma, there have been some studies that have shown that nicotinamide levels are reduced in glaucoma patients, thus resulting in the postulation that supplementation of nicotinamide can help increase the NAD levels in the retina. Subsequent studies in mice have shown that nicotinamide supplementation is protective to retinal ganglion cells, and this resulted in the human trials being conducted, which were led by the group at Centre for Eye Research Australia in Melbourne. So if we look at this study that was done in Melbourne in a bit more detail, it involved 57 patients with glaucoma, and they were randomized to placebo versus nicotinamide supplementation. And the nicotinamide supplementation started at 1.5 grams per day for 6 weeks, and then it was bumped up to 3 grams per day for another 6 weeks. At the 12-week mark, the patients crossed over. So the patients that were on the nicotinamide arm started to get placebo, and the patients in the placebo arm started on nicotinamide treatment. And there were measurements done every 6 weeks for all patients. Only 8 patients dropped out of this study at various stages because of various reasons, but it was generally well tolerated. There was only mild GI side effects reported in some patients. So there's a total of 49 patients included in the final analysis. In terms of the endpoints, the endpoints were ERG, specifically looking at the inner retinal function measured by photopic negative response and positive scotopic threshold, which are parameters of the ERG that are generated by the retinal ganglion cells. So if we look at the ERG changes, at 12 weeks, there was improvements in the inner retinal function in the high-dose nicotinamide arm, with 23% showing improvement on their photopic negative responses compared to 9% in the placebo group. However, at the same time, at 12 weeks, 9% in the placebo group had deteriorated, but so had 7% of the nicotinamide group. In terms of visual field changes, there weren't any significant differences between the groups. However, this is likely due to the short duration of follow-up. So it'll be interesting to see whether these ERG findings translate into visual field improvements or changes over a longer duration of follow-up. In terms of IOP and RNFL thickness, nicotinamide didn't appear to influence the IOP, mean arterial pressure, or the RNFL thickness. So there's now a larger trial underway with a longer period of follow-up, and it'll be interesting to see what becomes commercially available as a result of this trial in terms of supplements as well. I know I have some patients that do ask about giving or taking vitamin B3. However, the current commercially available supplements just aren't at the doses that were used in the trials. So currently available tablets come in 100 to 125 milligram tablets, and the dose was up to 3 grams in this study. Let's now look at brimonidine. So brimonidine is as a neuroprotective agent. As we know, it reduces intraocular pressure with its alpha-2 agonist actions. It has been investigated as a neuroprotective agent in various experimental models. And the neuroprotective agent effects of brimonidine are thought to be by inhibiting cell apoptosis by inhibition of glutamate and reducing the pro-apoptotic gene expression and increasing the anti-apoptotic gene expression in injured cells. It's also thought to support neuronal regeneration by activating brain-derived neurotrophic factors and fibroblast growth factors in the eye. Animal models have shown enhanced survival of the retinal ganglion cells independent of the IOP. So this was a study in rat models looking at inducing an IOP rise by cauterizing the episcleral veins of rats. They were then administered intraperitoneal brimonidine. One group was administered intraperitoneal brimonidine, another was topical brimonidine, a third was topical latanoprost plus brimonidine, and then there was a control group on no treatment. They found that, as expected, the topical agents, so the topical brimonidine and topical latanoprost, reduced the IOP and also had some effect on retinal ganglion cell survival compared to the control group. The intraperitoneal brimonidine did not affect the IOP, but interestingly, did have an effect on the retinal ganglion cell survival at 12 weeks. The other study that sort of looked at this as well was the low pressure glaucoma treatment study, which found that in comparison on brimonidine and timolol, even though they lowered the intraocular pressure to similar levels, the visual field progression appeared to be lower in the brimonidine group versus the timolol group at 9% versus 39%. However, one of the criticisms of this study was that almost half or more than half of the group on brimonidine was lost to follow-up. So if we assume that this group stopped their medication and progressed, the rates of final visual field progression would actually be similar. So in terms of brimonidine, the jury is still out. There's not many great studies that I could find looking at its neuroprotective effects. So it still remains to be investigated. So now we'll look at bitoxolol. Bitoxolol has sodium and calcium channel blocking abilities. And in lab models, it's been shown to rescue retinal neurons. So there have been a few studies. However, a larger randomized control trial investigating its neuroprotective effect in glaucoma hasn't been conducted. So there's not a lot to say about bitoxolol at this stage, and its role is still in question. Coenzyme Q10 is an agent which reduces the reduced antioxidant levels in conjunction with raised oxidative free radical damage, as we discussed, has been implicated in glaucoma pathogenesis. CoQ10 is a cofactor in the mitochondrial respiratory chain and is thought to be an antioxidant by scavenging these free radicals. This study in 2014 in the Journal of Glaucoma in a small group of patients found that in patients that were already on a beta blocker, adding topical coenzyme Q10 plus vitamin E drops improved their pattern ERG and VEP responses. However, further trials on this agent are still lacking. So that's another agent that needs further investigation. If we now look at the neurotrophic factors, there are various neurotrophic factors at different stages of their investigation in clinical trials to investigate their neuroprotective effect in glaucoma. If we talk about brain-derived neurotrophic factor, this is a neurotrophic factor that's produced in the retina in response to the injury of retinal ganglion cells, but it's also transported in a retrograde manner by production in the brain. And this retrograde transport from the brain to the eye is interrupted in glaucoma and thought to contribute to the degeneration of retinal ganglion cells. Low levels of brain-derived neurotrophic factor have been found in the vitreous and serum of glaucoma patients, and local administration of BDNF has been shown to improve RGC survival following injury. So this is one that is currently undergoing investigations and further trials. In terms of gene therapies, gene therapies have shown good results for single gene diseases like Leber's congenital amaurosis and Leber's hereditary optic neuropathy, but glaucoma is a multi-gene disease, which makes it difficult to know which genes to target. Current experimental studies have shown some promising results in this TRKB BDNF. So this is a gene therapy which looks at trying to upregulate BDNF, but also its receptor. So the problem with just upregulating BDNF alone is that, or even administrating exogenous BDNF, is that there's a reactionary downregulation of the BDNF receptor, which is this TRKB. So current gene therapies are looking at ways to increase the expression of the neurotrophic factor, but also its receptor. And they've been shown to be protective against ganglion cell loss, and it's currently undergoing phase 2 trials. There are some trials on the myocilin gene in juvenile open-angle glaucoma, and this TEC or tunica endothelial cell kinase in congenital glaucomas. So in summary, there was a lot to cover, and I'm sorry it was a bit of a quick summary of each agent, but there are many agents in both the IOP lowering category as well as the neuroprotective category. Some are in their preclinical trial phase, and many are undergoing ongoing clinical trials currently. In terms of what's in clinical use, there are agents which are available to us, such as Rapazidil. However, they haven't been taken up as quickly as we can because of the limitations in accessing these drugs, particularly in Australia. Great, that is the end of my talk. So I'll stop my screen share there. Any questions from anyone?
Thank you, Dr. Rhuju, for the presentation. A nice one, and I think many things are new to me. Maybe it's new to some others too, so I expect some question in the chat. I think we have one question for now from Dr. Siska Mayasari. She asked, oh, okay, maybe, okay, she said that most of the drugs that you explain are not commercially available in Indonesia, such as the one that available in Australia, like Rapazidil, it's not available yet in Indonesia. So she asked, when you consider using neuroprotective agent in glaucoma, and should we use the neuroprotective agent in all stages of glaucoma? I think you can answer.
Yeah, I think if we could find one that we are confident that works, then yeah, it would be great to use it in all stages of glaucoma. The problem with the neuroprotective agents is we still haven't really proven that any of them are completely effective in slowing down the retinal ganglion cell damage and death. It'll be interesting to see what happens with these bigger vitamin B3 trials. So at the moment, I don't recommend it routinely for any patients. There's nothing really to recommend at the moment, but I don't tell patients to go and take vitamin B3. But if they ask about it, I say you can try and take the commercially available dose. It's not as high as what's been used in trials. But yeah, I don't. Yeah.
Oh, yeah.
What about you, Prof? What do you tell them when they ask about vitamin B3?
I'd say the same thing. The current trial evidence is tricky to interpret, I think. I'm just trying to, it's been a while since I read the literature, but there's some ERG evidence in animals that there's slight improvement, but that doesn't necessarily translate to ongoing resuscitation in a glaucomatous situation. So I think what you're saying is very true. We don't really know enough and we'll need to wait. I was part of the memantine phase 2 and phase 3 trials, which is now about 10 or 15 years ago, actually. And we all had great hopes, and memantine, the end result was very interesting. The drug company spent hundreds of millions of dollars on that trial. It was a very expensive trial to run. And in fact, there were 2 doses of memantine. There was the standard dose, half the dose, and placebo. And the half the dose ended up doing slightly worse than the placebo, actually. And the full dose did about the same. I think it might have been the other way around, but either way, certainly memantine had no beneficial effect beyond placebo or control, which was certainly very disappointing to the drug company. So I think many people are fairly wary of the neuroprotective agents. One thing, Betaxolol is an interesting drug. And there was a French study about 20 years ago where a French ophthalmologist claimed, and had some evidence, in fact, that there was some visual improvement in patients with severe glaucoma using visual field criteria. Now, everyone poo-pooed the idea of there being visual field improvement, but more recently, the notion of being able to improve visual fields in glaucoma has gained a little bit more currency in terms of it not just being dismissed out of hand, but being considered. So And Betaxolol is a very safe drug. It certainly has calcium channel blocking effects at the level of the retina when applied topically. It's the only one that I use very occasionally in patients with end-stage glaucoma where you've got their pressure down to, say, 11 or 12. They've got a visual field, a bit like your patient, Diana, who had almost unrecordable visual field. You're petrified about operating, and in fact, you don't really think that by operating you'll get a lower pressure anyway. You'll just submit the patient to a pretty high risk of sudden visual loss. So those patients, I will sometimes offer them Betaxolol if they're deteriorating either subjectively or objectively. But that's probably as far as I generally take it, basically, at the moment anyway. But Rhuju, really very nice talk. You summarised, I think, the new drugs really terrifically. One question, Ripasudal, I've used it on about 5 patients now. I haven't had any success, actually, which is quite disappointing.
I was just about to start it on this guy on maximal medical therapy, just as a clutching at straws.
Well, you should. I mean, yeah, that's exactly the same reason I've used it. I was clutching at straws, trying to prevent people from having to have surgery. Try it. Like you say, it's $90 a bottle. It's expensive. I have been using it twice a day. That was the original dosage recommended by the Kowa, the Japanese company. And I'm not sure what the correct dosage is, whether it should be once a day, or I notice some people use it once a day as well. That you look up the pharmacokinetics, and some reports say it only lasts for an hour. So it's actually kind of, it's interesting to hear that some people are using it once a day. I'm not entirely sure how often it should be used, actually, whether it should be once a day or twice a day. Yeah, sorry, they're my only kind of comments. They're really very nice talk, and the case presentation was lovely as well.
Thanks.
Prof. Morgan, would you tell us more about your experience with that Ripasudal? Is it do you give it in patient with multi-drugs first, so you give it as a combination, and you don't find any more IOP reduction? So
yeah, it's always been in combination with other agents. So they're usually on maximal medical therapy, so probably 3 or even 4 other agents. And I've added it in, hoping to bring the pressure down, but I haven't had success. So now it might be just I've been unlucky. It's certainly not a controlled trial. It's just my anecdotal experience, that's all. It does have fairly high rates of conjunctival hyperemia, so that's one thing I warn the patients about. No one's complained, as in I haven't had any nasty side effects from it, so patients have been happy to use it. Just unfortunately, it hasn't worked. I mean, I'll still keep trying for a bit longer with it. I haven't given up.
yeah.
Prof, were these eyes, sorry, Avi, just wanted to ask, were these eyes that had any glaucoma surgery in the past, or a mixed bag? Were they?
I think they were largely virgin. I don't think they'd had, I was trying to prevent them from requiring glaucoma surgery. Yeah, they might have had a Zen stent, but I don't think any of them have had trabeculectomy, or certainly no glaucoma drainage devices. Yeah.
Okay, yeah.
So, Prof, I would like to ask about the citicoline. Do you have you used it for your patient, the citicoline as a neuroprotector?
Which one, sorry?
The citicoline?
Oh, no. Yeah, I know. That's not available in Australia, actually. I know it's available in Indonesia.
Yes.
You might just, sorry, could you spell that? I think you say it, it's an interesting drug, that one. Do you mind, because our Australian colleagues are not familiar with this.
This one on the chat, can you see it?
Citicoline, yeah.
Yes, and we have this one, the brand is, one of the example is this one.
Hmm.
Because sometimes I use it with a dose of 1,000 milligrams. And I think some study also support that. But yeah, I think the outcomes are also the ERG, not the visual fields. So we have Dr. Firna too. What do you think, Dr. Firna? Do you use also the citicoline, the neuroprotector?
Yes, actually, the first study was done by Prof. Ike on 2009, and she got, I think Prof. Ike could tell about the study as well. But the last one that I did with my students was comparing the citicoline 1,000 and 500 milligrams actually, and it seems that it works with the visual field examination and also with the OCT examination. For the clinical practice, I have some of my patients feel that the visual function getting better, Prof. But I don't know whether it is just like a subjective condition, or but the patient told me that he getting better. And then when in some patient as well, I did the visual field test again, so I did the retest, and it seems that there is some progression. I'm sorry, positive effect. I mean the condition is getting better, but not that much, but it is quite good, I think. And I know in Italy, when I went to Greece, I saw that one of the Italian company produced citicoline as an eye drops. But I don't know because I didn't attend the industrial symposia at that time, so I don't know how it works. But it does. I mean, they produce the citicoline as an eye drops, but my studies actually using it as an oral. So it is like for the neurologic disorders. Most of like stroke patient use this. So actually we learned that because of the neurology department use that. Maybe that's all, Prof.
Yeah, thank you, Dr. Firna. Actually, our time is up, but maybe if you may, Dr. Rhuju, we can answer for just one more question.
Yeah, sure.
Yeah. So this question is from Dr. Shafiq. He asked that one of the common side effects of glaucoma eye drop is irritation, which could lead to ocular surface toxicity and affecting patient's adherence. Would it be prudent if glaucoma drops, especially with multiple eye drops, are prescribed simultaneously with preservative-free artificial tears to prevent irritation? Thank you.
Yeah. Yeah, I think that's a good idea. And I certainly tend to do that. And also preservative-free glaucoma drops if the patient has bad ocular surface disease. Do you have many preservative-free glaucoma drops available in Indonesia?
Yes, we have some.
Yeah.
Yeah.
Yeah, so that's what I do. I find that putting them on preservative-free glaucoma drops usually tends to sort out a lot of those ocular surface intolerances. But yeah, I do put them on preservative-free lubricants as well.
And would you prescribe it simultaneously sometimes with artificial tears for patient with multiple drugs? Yes?
Yeah.
So do you have any comment, Prof. Morgan?
About preservative-free?
Yes,
drops.
the preservative-free eye drops, the glaucoma drops. And also, would you give the artificial tears like simultaneously with the drugs, or you will wait for the symptoms to give the artificial tears?
Yeah, I usually wait. I try and minimize the number of drops people are putting in. So if there are combinations of the drops, I'll generally try and use them, mainly for compliance reasons. Also, the more drops somebody's on, they'll probably put them in close together. So I like to try and encourage them to put them at least 5 minutes apart so that one drop's not just washing the other drop out. As I don't routinely use the artificial teardrops. I think if patients, most patients' ocular surface tolerates 1 or 2 eye drops. So I don't see the reason, but then if they are getting symptoms and there are signs, then yes, I'll certainly use artificial drops. I think I gave a fairly lengthy talk on preservative-free drops last week. Yeah. So that's not a straightforward answer there, but some patients do benefit from preservative-free drops, but I don't think that's necessary for everyone, be my short answer.
Thank you.
Yes, sorry, I think I I don't put everyone on preservative-free artificial tears, but I thought the question was asking if there was problems with the ocular surface toxicity or patient adherence. So yeah, I wouldn't routinely put someone on it just because they're on maximal medical therapy or multiple agents, but if they're getting problems, then I might try it. Yeah.
Thank you, Rhuju. I think we have passed our time. So I would close this meeting, but before that, do you have any more addition or comment, Dr. Firna? Or Prof. Ika?
No, thank you.
No? Okay. So I would invite first for all the participants, if you're able to open the video, we would love to take photos. Okay, so we have here more than 120 participants tonight. Yeah. Okay, I will start to take the screenshot. Okay, the first one. 1, 2, 3. The next one. Okay, that's all. Thank you, everyone. Thank you, Prof. Morgan, Dr. Firna, Prof. Ika, Dr. Rhuju, and also Diana.
Thank you, Prof. Morgan.
Thank you. Thanks, everyone.
So we'll see you again like next month. Good night.